one of the points I tried to make, I guess, in my lecture is this idea of the disorganization of care. Now, I don't mean that in a critical way. I don't mean this is a disorganized service, but there is a sense in which the unique needs of individual recipients of care can lead to very complex configurations of services, can't they? And negotiating that and having threshold criteria are going to be very important to manage different professional agencies and their involvements, I guess. Any other questions before we move to the second case? Do stand up and wave, because it isn't the easiest room to see everybody in. Yep, at the back.
Hi, I just want to ask, usually for the assessment of capacity in this kind of situation, would the doctor or whoever is assessing also take into account these kind of, dysfunctional family dynamics, and how much of that impacts capacity? I mean, to the panel or to the rest of the audience?
That's a great question. How do we take a capacity assessment and how does it interact with the relational dimensions? I'm looking to Stephen and Tabitha. Stephen, do you have anything to add? It looks like you're skeptical, but go on.
Yeah, I'm hoping that a doctor somewhere in the audience can answer this question. Okay, I think mental capacity is a bit tricky, but for us, of course, to assess and to qualify a person without mental capacity has to be have to do a proper assessment. But as a caseworker, when we go in, when we interact with the person of concern, for this case, John, we make a judgment, not a judgment to see whether assessing mental capacity or there is a value in doing the mental capacity test. I mean, as a caseworker, this is what we do in the community. And then the challenge is getting the mental capacity properly assessed. That is our challenge. You get the doctor to come in, you get the person to see a doctor, already the person has some refusal of care or not cooperative, and then how do you get that? And then to us is, what is the value after you diagnose a person or determine a person without mental capacity, whether it deter the management plan drastically, whether there's a value in it.
Thank you. I hope that addresses the question. I'm always struck, I guess, also thinking about the main legal precedents on the MCA in Singapore, particularly thinking about BKR, how the configuration of capacity itself incorporates an interesting relational dimension that we don't see in other mental capacity law jurisdictions. So that strict delineation between problematic relationship and mental capacity, I think, is not borne out with how the law has evolved in Singapore in very interesting ways. We might be critical of that, we might endorse it, but it's certainly an interesting feature, I think, of the case law. Okay, so we move on to our final case for the day. A very different scenario, and we've posed a quite provocative question, but I don't think we need to be limited to that question: is a family caregiver negligent? It raises interesting questions, I think, about vulnerability and care relationships, but also how we think about the boundaries of abuse and neglect in important ways. So we'll have a similar discussion, but I'll read it out first. Mrs. Molly Tan cares for her husband George, an elderly man with dementia. Molly is struggling to cope with caring for her husband. She's sleep deprived because George wakes up several times a night and wanders about the house, taking apart household appliances and asking to go outside. Recently, George put on the empty electric kettle and nearly caused a fire. Molly has told close friends that she cannot trouble her children for help at nights or call for professional sitters to help keep an eye on George, as she can't afford it and does not believe it would work anyway. Her friends think she's being stubborn and impractical. One day, Molly fails to bathe George, as she normally does every morning, because she is tired and wants a break. She goes out to the local coffee shop to have a cup of tea and to buy the day's meals as she's too tired to cook. When she returns home, Molly diapers George but does not bathe him, thinking that she will bathe him the next day. Okay. So we're going to pose the same questions to you and to our panel as we posed in the same case. And it might be helpful just to start with juxtapositioning this case with the previous one in some regards, in thinking about whether, firstly, is George a vulnerable adult? And is George being subject to abuse because of Molly's behaviour? So again, I'll open it up to the audience and ask initial reflections before the panel come in. Do you have a strong sense of the answer to this? How does it differ to the first case? Please.
I think George is a vulnerable adult in this case because he is dependent on Molly for care, even for basic ADLs as well. So he's definitely a vulnerable adult. As to whether he's being subject to abuse, I would say it's more of a neglect. You can say maybe even substandard care on the part of Molly, even though it seems unintentional on Molly's part. Yeah.
Thanks, really appreciate that. So you're tying his vulnerability, I think, here, if I just want to reiterate the point, and we'll come to you, thank you. Tying his vulnerability to that dependency on Molly, importantly. And also a neglect type case, perhaps rather than an abuse case. You also drew a distinction, interestingly, between neglect and substandard care, something I think we might want to think a bit more about as we go, but please.
I'm Ka Ching, I'm a family physician. So yes, I think we all agree to the answer to question 1. Question 2 is really subjective, depending on what we determine to be a good care. Within the caregiver's ability, she would be very elderly, possibly frail herself or pre-frail. And this level of care that she has been giving, is she going to be able to continue it? And if she's not, would the next level of step-down care be still appropriate? So we are talking about her just taking this day of not bathing him, but if it continues, then yes, there may be a problem. But otherwise, as a clinician taking care of many demented patients, I sometimes tell caregivers, you know, you don't really have to bathe him every day. Yes, you know, you can just diaper him and clean the axilla, the groin, the buttocks, and that's all. So, you know, so that's a big question mark there. And of course, then the next step is to call in help. I didn't realize how difficult it is for a caregiver to call in the help of secondary caregivers, be they siblings or aunts or whoever, until I myself was for a while a caregiver. And I just felt that, no, I couldn't trouble my brother. He's got children taking O-levels, A-levels. No, I can't trouble my sister. She's so busy with her work. And since I work part-time, I should be the one taking care of my other sister. So yeah, so these are a lot of issues that can be addressed in this case.
Wonderful, thanks so much. I do like the way in which you positioned the questions in that terms of that kind of care journey I spoke about earlier. It's very difficult to interpret and assess this scenario without thinking about what comes next and how this might change over time. And I think that is a very important observation. But you really nailed, I think, one of the key questions in this case, for me at least, which is, how do we think about standards of care within families? How do we think about substandard care? How do we think about deviations from that? I mean, these are not professionals who have clear obligations in place. How do we make sense of that? Anybody else like to come in on that point? Yeah, please stand up. There's a mic coming around, or one over there.
Hi, I'm Jing Yi. I'm a MSW. I think there was a recent case last year, GER and GES, where they actually talk about what would be defined as neglect. And I think how the court actually defined it was based on what would be considered essential care. And essential care would be something like, I think they have to decide what would be within the range of reasonableness. So for example, is it reasonable for them not to shower them every day? Actually, pretty much, right? Because we have patients who need two-man assist in order to transfer, and there's only one caregiver. So perhaps like twice a week when HPC comes in, and then they get to have an additional help, and then they get a shower twice a week only. And that's actually quite reasonable. We wouldn't consider it as neglect. So I think it really depends on the facts of the case, and I think sometimes we really need to accord, especially for caregivers who are very genuine and they really try their best. I think it's important to accord them that grace and that understanding that they are really doing their best, and how else can we put in services to further support them so that the patient gets a slightly more optimal level of care. Because the alternative is to remove them and put them in an institutionalized care, which is not ideal. Yeah, and I think it might actually do more harm than good, not just to the elderly, but also to the caregiver. Thank you.
Thank you. Well, we'll come on to the question about how we should respond in a bit, but I do like this idea of invoking this reasonable test in the context of that family setup. What would it be reasonable to hold Molly to in terms of her standards and expected standards in that relationship? It's a very important question to ask. I see a hand at the back and a hand over here. Can I come over here? Yes, thank you, first, and then we'll pass back to this side.
I'm Caroline. I'm a pediatric surgeon. I actually wanted to ask, we actually have potentially two vulnerable adults here because Molly has got sleep deprivation and she is also got caregiver burnout. So in this situation, it's two vulnerable adults. So who's protecting Molly?
Wonderful. We hoped somebody would get there, and they have. That's fantastic. It seems absolutely right that we assess and think carefully about Molly's vulnerability. And what we owe to Molly seems as much a reasonable question to ask as what we owe to George. I think that's absolutely right, and we'll come on to that.
Hi, I'm Giles. I'm a psychiatrist as well. I'm sorry for the echo. It was just sort of the point made earlier. The MSW made a very good point about the reasonable care. So I think and also the predicament and the challenges of the single caregiver. So if in this scenario, the vulnerable adult is not getting the standard of care that would be expected in a reasonable way because of the constraints placed on the carer, there's clearly a gap. So if you were to sort of look at the caregiver's point of view, then that's entirely reasonable. But if you were to look at the point of view of the vulnerable adult, that is not reasonable because actually they may get rashes, they may get infection and all that sort of thing if it's just twice a week that they get proper wash. So where do you square this? Where does the test of reasonableness, how is that actually arrived at? And if there is this gap, then whose duty is it to fill that? Thank you.
A wonderful question. How do we ground a standard of reasonable care? Whose perspective do we take? Do we take Molly's? Do we take some objective account? Do we take George's? That seems like a really important question if we're going to make reasonableness do the work. I don't think we can answer that right now on the stage. I think we'll come to talk it through, I think, with the audience and with our panel members. Owen, you'd like to come in? Please do.
Yeah, thanks. Owen Schaefer from the Center for Biomedical Ethics. Just wanted to highlight, we've been focusing on the last part of the anecdote in terms of whether or not there's been neglect here, but just to reflect on the first two paragraphs as well, where it seems a case for, if not neglect, substandard care could more easily be made, George has been let around the house where he's taking apart appliances, almost caused a fire. And furthermore, Molly has been declining assistance that could be used to potentially monitor and prevent this from occurring. Right? Serious harm could obviously occur if a fire was started or other injury was caused by the appliances or other activities. My view is that maybe for the third paragraph it's reasonable to bathe fewer times a day, but if Molly is refusing without good excuse, refusing aid if it's possible to get aid, and Molly is actually actively declining that aid that puts George at danger, that might be closer to falling below a standard of care. Over.
Thanks, Owen. Yeah, so you're picking out two very important objective markers of why we might be concerned about the standard of care, even on a reasonableness standard, in the evidence we have in front of us in that information. Thank you. So we'll come back to the audience. Don't worry, we'll have more time to ask some questions of the panel. But I do want to hand over perhaps to Wei Ling and Dwayne first, just to comment on this case as care partners. How do you interpret it? How do you make sense of this? Does it chime with you? Does it resonate? How would you think about vulnerability or abuse or neglect in this situation? May I give you the mic and allow you to comment, either of you, to start with?
Yeah, George is a vulnerable adult. He can't even he has a dementia, so he cannot help himself. So we can rule that he is vulnerable. And question that number two.
Is he subject to
yes,
abuse by Molly?
Yes, I know. Okay. George is, because he's vulnerable, he can't even bath himself. So whatever Molly does, George will be abused by her. Yeah.
So what you mean is he is reliant on Molly's care. And if Molly doesn't execute that, it's abuse, right? Is that what you mean? Okay. So again, I will cite an example of a friend whose mother was 93, was because she passed on in January. For the last 3 years, she was deeply sleep deprived because the mom will wake her up at every other hour for, like, I need my medicine, I need to go to the toilet. And then, of course, as friends, not professionals, informer, I just learned this term, informer caregiver, or we prefer care partner. She will, I say, how about you pretend to be asleep? Don't wake up. And she say, no, but she will come and shake her and then wake her up. So she has not been able to sleep properly for 3 years. Getting a professional helper was ruled out because of bad experience. Also, like getting like daycare or nursing home was ruled out because her mom is not a Singaporean, so it's a financial burden. So eventually she left a job because it was too much pressure from work pressure and a home. And for a year she was not working until recently when her mom passed on. Yeah. So was she vulnerable? Yes, like what just now the lady mentioned. To me, Molly is also vulnerable. And this could, a caregiver, we have seen cases, care partners go into depression. So we have to look at both. And again, I always advocate not just the person, the patient or person with dementia or whatever health condition they have, there are care partners or caregivers, and a third party may be, which is the community, could be the doctors, the professional, friends who can give some respite to the care partner. We are in a community of, Dwayne is has young onset dementia, so we are in a community of young onset dementia social club, which we help each other. He always says, "Sis, when you say you understand me, you actually don't understand me because my condition I go through myself. But then I myself need respite sometimes, because I do feel the responsibility of, although he doesn't need caregiving, he's perfectly fit and all that. But he needs some support in prompting, doing things, help him with learning and socializing activities to help him slow down the progression. And that is very important. And that's where I think the community is important. And in this case, it's really George and Molly only. And she kind of doesn't take the advice from friends. Could be the personality, could be the network she has. So we were in the Voices for Hope program run by Dementia Singapore, and it's a 10-week program. I'm not selling the program, okay, but it's a program that helps us go through what the person with dementia experience, what are the goals that we can look into, the communication and all that, and that we learn together, partner together. And I have also a shout out to Michelle and Uncle Thomas. They are the co-facilitator for this new cohort, and we have that network. So don't keep to yourself, but start early to connect others, and then you'll get the help that you might find, getting ideas. She might be very stubborn now, but if she sees that the result of similar cases is positive, she might adopt it, might adjust. So we always adjust and adopt together with his, their condition as they progress, or not, hopefully not, of course. But yeah, so I think about home and community care, we have to bring in the community as well, because it does take a village for not just dementia, Alzheimer's, but other conditions as well.
Thank you both. That was wonderful. Really helpful to have that perspective. I'm very interested in what I took from that, which was essentially that you have to sort of see the relationship as an organic thing. That families are caring, and that comes with burdens for many people. It's a transition. You take something on. It's new, and it changes. Your relationships change. Your relationship to the burden will evolve constantly. This is another sort of dynamic phenomenon, really, and we have to be aware of that. I'm very interested in this idea of, it takes a village, and how the community might be the source of resolution to this case. I'm interested to hear more from that in a bit, rather than perhaps say professional care groups. We think about the community response. That's very interesting. But before we go to that key question, what should we do? How should we intervene? How should we support George and Molly together? Stephen, anything you'd like to add in relationship to questions of vulnerability, neglect, such like in the case generally?
I think I do agree with what the audience and Wei Ling and Dwayne have shared. I would like to highlight one point in such a case study. It's getting more and more common, because I think our society ages, and then couples don't have children, or you have young person with dementia or certain vulnerability staying alone, and this to me is quite a common case. One thing that I would like to highlight a little bit more, which was mentioned in the audience, who is supporting Molly. We know that George is dependent on Molly, and then Molly, to me, seems like she is also vulnerable. And then the question just now brought up by our audience also, who is supporting Molly? That is very important, because when you look at when Molly, for some whatever reason, if she is not able to provide care, and then she collapses, either depression or some chronic illness or acute sicknesses set in, and then partly due to caregiving duties, and then what happened to the family? You may have potentially two persons needing care rather than one person needing care. So my question is, what is in place to support Molly in order to empower Molly to support George for this case, right? Yeah. So there is a big question. And then the two things that I would like to assess is, okay, I mean, besides whether abuse happened, is whether Molly has the, first of all, motivation. I think generally by what we read in the case study, the motivation for caring is there. But whether she has the capability and the capacity to care for George, and then not now, but in the longer term, I think it's a big question mark. If we have the opportunity to build in the capability and capacity, then it can be include like what Wei Ling was saying, connecting to a support network, understanding dementia, getting to know what are the resources, what are available out there, what are the help available out there. Probably we can do these two for Molly during this period of time, then don't wait for things to turn very ugly, for example, to the brim of really abuse happening. Yeah, so then these are the questions that I would like to, these are the points that I would like to highlight a little bit more.
Please do, yes, come up to the microphone.
Hello everybody, I'm Michelle. As you know, I care for that lovely uncle over there. I just wanted to add on to what Wei Ling and Stephen shared earlier on. Nobody gets an experience until you get launched into it. Like you don't know how to become a father and mother until you become a mother and a father. It's the same thing for caregiving. I never knew what it was like until I got launched into it. And one thing I will say, it's like all medical professionals here say, early diagnosis is key. Because only with an early diagnosis, then you can put in all the necessary steps for prevention to maintain or sustain the condition. But I'd like to put out the notion there is catch the carer or the care partner early. Send them off into, doctors can refer to psychological social help. They might say, yeah, I don't need. But really, until you get into that moment and that space, right, let's catch them first before Molly gets into that position of being vulnerable herself. Yeah, does that kind of make sense? Because if not, then Molly gets into that stage, then she becomes vulnerable herself. And one of the key things with care partners that I've, in my experience of now working with Voices for Hope and care partners, even acceptance of their loved one's condition is not even there, let alone how do I then be a care partner or a carer, right? So catch them, educate, share, support them in whatever that's necessary. Now, I get it. A lot of care partners like myself go, no need lah, I can do this on my own. But how can we then get them into a level of quicker acceptance so that they can be better care partners for their loved ones? Whether it's dementia or not, it could be, chronic illness and all of that. And that's something I just wanted to put out there. Thank you.
Thank you very much. Really important experience you shared. Thank you.
Just wanted to add something to what Stephen and also Michelle just said. I think they tie together because Stephen pointed out, as one member of the audience said, that there can be more than one vulnerable person, which as you saw in this case. And actually, if you think about it, in the earlier case as well, how do we know that this daughter-in-law wasn't a vulnerable person as well? I mean, we don't know whether the father-in-law was manic depressive, might have been a risk to the kids, that's why he was locked up. So I think, I guess, yeah, when we talk about cases, and I think the earlier panel also pointed out, complexity is everywhere. And so when we focus only on one vulnerable adult, we might miss the systemic problem. To Michelle's point, actually, I agree wholeheartedly, but I would take it even one step further. Instead of trying to provide early training or intervention for the caregiver, why don't we accept that all of us at some point in our life journey are going to have to be caregivers, especially in view of the demographic. So, and I've been doing this experiment for almost a year now. I actually work part-time at a daycare center now that I'm past 55. And the experience has been enormously rich because I'm getting a preview of A, what it's like to have to care for my mother when she's in that state. B, what it's like to be for me when I'm in that state. Because at some point, I'm going to get old as well. And rather than wait until I'm a caregiver to get that training, I might as well get the training now. And so actually, there's a point which I think one of our MPs raised last year in Parliament, and unfortunately, I don't think it was given enough thought because the Defense Minister just dismissed it outright. But if you think about it, national defense is not just military defense, it's social, it's psychological, all the other stuff. And if we get all our young people to do some form of national service in caring for others, it doesn't even have to be caring for elderly, it can be caring for the disabled. You've equipped a future generation of people who actually have the skills and the empathy to do the job when we need it. And what's the point of having military aircraft, shiny machines, which can defend us militarily if we're crumbling from within? And I think that's the point which I'm not sure they gave that enough thought. Because they said, oh yeah, we don't want our girls doing that kind of stuff. But actually, we're missing out half the population if we only make the boys do national service, and if we define national service as military service. If you define national service as total defense, then every male and female teenager should be able to contribute. So anyway, that was a long discursive thing, but I think that allows us to broaden the envelope far beyond just the care of people when they are in the need, rather than, and so it's anticipatory as opposed to fixing it when the problem is in the middle acute situation.
Wonderful, thanks. That's really helpful. I mean, I love the idea. I'll come to you in a moment. I love the idea that the right kinds of response to challenges in care lie at the social level. They lie in thinking about what it means to have obligations of reciprocity within our community, and maybe broadening out of the kind of professional world to thinking about the social level is actually where we need to go. I also like your point about binaries, and there is a danger in adult protection generally, I think, and in caregiving to say, look, there's a caregiver and a care recipient. There's an abuser and there's the person who's being abused. But if you look at the relationship and the dynamic, we see a much more complicated story, I think, most of the time. Thank you so much. Please.
Yeah, so thank you for all that robust discussion. So it just crossed my mind because of the nature of my work, right? So we are talking about the vulnerable adult, and here we identified there's the other one in the shadow. So I really look at the patients I manage as being in a vulnerable setup, a vulnerable family, be it a two elderly couple with an elderly and frail caregiver, or be it a very old person with an elderly child who is also the caregiver. And so a lot of times we talk about the patient seeing us, but in our setting, delivering care, we are really caring for the dyad or the triad, yeah. So I think harnessing all the support services on board timely and especially early, I would say, would really help us mitigate many of the problems further down.
Thank you very much indeed. I think we will now shift to our final question. I think, if I'm honest, we've already been interrogating this question together so far, but let's really move on to this question about how do we respond, either as a society or in terms of professional supports, in terms of preventative interventions, as just been mentioned. What is the right kind of response, and who is targeted? Where's the support addressed? Tabitha, I mean, as an adult protection person in that world, I'm very interested to start with you and just get a sense for how you would assess this as an adult protection issue, or perhaps not, for your service, but how it might connect to other services as well. Would this be seen as the kind of thing where adult protection services would get involved? And how would you make sense of that? Thank you.
Okay, so I think if we look at the so-called facts of the case studies, George is definitely an adult, a vulnerable adult under the VAA. I'm not too sure about Molly if I put on the lens of VAA, because there is no information to suggest that, she's definitely above 18, but I'm not too sure if she has a physical infirmity or mental infirmity, because I think the VAA strictly looks into that, and because of that infirmity, she cannot protect herself from abuse, neglect, or self-neglect. So that one is a question mark for me. Then pertaining to so-called the allegation of neglect, I don't think that this has met the threshold for statutory intervention to come in. Yeah, definitely she is experiencing caregiver stress. She needs to be helped. And there are potential areas whereby, you know, her network of support could be expanded to. But of course, currently, from the reading of the case study, she's not quite open to it. So I think that needs to be explored, and like kind of, I guess the boundary with her needs to be pushed a bit, you know. If not, my worry will be like, you know, it will escalate into a situation whereby the concerns get like bigger, and the impact on the care or the standards like really drop rapidly, and the impact would translate onto the care, on the safety or the well-being of the vulnerable adult. Yeah.
Thank you, Tabitha. That's great. So, not obviously an adult protection issue for you, I think, in the way you've described it, but clearly vulnerability is present, worries in terms of care provision and burden. Some response is called for, but perhaps not the statutory adult protection response. Rather cheekily, Stephen, I might come to you, if I may, and say, you know, as another professional around the table, how would you assess the needs of this couple? How would you make sense of, you know, the right form of response? We've heard some comments from the audience about the need for preventative intervention, the worries about what will happen next, but also this idea of relying on the community or thinking about broader social programs potentially. How would you make sense of, you know, the right kinds of response?
Yeah, I think earlier on, Dr. Ng Wai Chong, if you happen to be in the session, I wasn't in the session, I must confess first, but I heard that he talked about person-centered care, person-centered care approach. Similarly, in this situation, for Molly, what is the acceptable help that he will take in? Again, we agree on, like, you know, to get help earlier, to put in the intervention, but again, it is subject to whether Molly is agreeable. In fact, like, you know, when John may not be able to give the consent, and then a lot of services will turn to Molly, whether ask Molly, do you agree to send George for this and this? So then we have to work with the decision maker and also the main caregiver. In this case, it's Molly. So then, for me, is we recognize that there is certain measure that can be put in place early, and I do echo what Wei Ling was saying, that, like, you know, a lot of them, you ask them, oh, do you need daycare services for George? She'll say no. I think it's in the case study, he says that getting the son to be involved in caregiving, she said, don't want to trouble the son. And then this, to me, there is some intrinsic or cultural values in the decision making, and usually they don't want to trouble especially people they love. Don't want to spend money. Don't want to spend because they think that, oh, all the money we have to safeguard for our next generation, for my children and for my grandchildren. So a lot of them have this kind of cultural belief ingrained in them, and then we have to respect that. We have to acknowledge and respect that. And then, to me, the lowest hanging fruit is actually a support network. A support network that, oh, why don't you go and then talk to other caregivers? And then from there, actually, things can escalate quite a lot. From the support network, they can share resources, they can share what are the other caregiving experience is about, other people who try and ask the children for help, or other people who, like, you know, apply for certain schemes. Like, for example, I don't know if Molly explore, not talking about services for George, even financial help Pioneer Generation Disability Assistance Scheme, caregiving grants, and all these things are available. Whether Molly is aware of this, to think that, like, they don't have to ask the children for money, and then they are self-sufficient, to able to make caregiving a little bit easier. And then with the additional resources, whether Molly agree to send the husband to a daycare center. As a professional, I can tell, hey, it's good for you. But when Molly hear it from another caregiver, it's a different story. The lived experience of it, the impact of it is very, very different. So I would like to, in a way that ease in, where is the best entry point for Molly to gain all this knowledge, to build capacity and capability as a caregiver, to be able to journey a little bit longer. When they are, even in fact, we also hear of among caregiver, if Molly did something wrong, the caregiver come to know about it, will tell Molly, hey, this is not appropriate. Yeah, we know about this, what can we do to help you? Rather than, oh, I'll report you to Adult Protection Services.
Thanks, Stephen. I think that idea of the power of sharing narratives and experience shared, in what is obviously a new role for many people, a difficult role to take on, is a really powerful one. Jacqueline, do you want to come in next?
Yeah, actually, I'm so glad that Stephen ended on that note, because I remember that Wei Ling said something just now about her mother, who had seen the GP with bruises, and nothing was done. And I think there is there's very strong incentive not to report or to notice when in the GP clinic or in the polyclinic, you are so busy. You don't want to take on an additional complicated area like reporting or investigating potential abuse. So there's a huge amount of under-reporting of potential abuse. And it's a really difficult problem. I know from speaking earlier with Tabitha as well, that there is a lot of under-reporting. So abuse just gets swept under the carpet. There is very little understanding of what's involved. I was wondering if you had any thoughts about redesigning monitoring in such a way that it doesn't disturb families when it's not appropriate to do so. And I think when Stephen said it's good to have many eyes, more eyes to look out and help, right? Something Wei Ling pointed out too as well. But let's say in the polyclinic, what are you supposed to do at this point? What is the prescription if you sort of notice something? And do you record it in the electronic medical health record?
Thank you, Jack. Anybody in the panel want to respond, or perhaps comment from the audience on those monitoring proposals, how we keep things visible, enable pathways of investigation and scrutiny? Is that part of the community's responsibility? Do we need new professional frameworks?
Okay, so I can maybe share a little bit on some of the work that we have done in the upstream, in the reporting. So we found out, MSF found out that the SGO, the Silver Generation Office, they've been sending volunteers, into, it started with the Pioneer Generation, right? Because they went in to visit the elderly, explain to them the schemes of the government, and their benefits and their welfare, stuff. So we kind of partner with them, and we found out what they did, and we kind of trained them to also pick up what are some of the signs in that sense. And I thought that's our way of trying to make things kind of a little bit not so invasive because they are already visiting, they are going down to visit the elderly. So that's one. And the other thing that the ministry has been doing is in terms of public education. So there is this campaign that we started, I think, in 2018 or 2019, and it's been still around. It's called the Break the Silence. In short, it's BTS, but not the Korean band famous, that one, yeah. So just happened to be the same name. So that talks a lot about the different kind of abuse, not just elderly abuse, or not just vulnerable adult abuse, but also family violence, child abuse, you know, talking about the need to break the silence, like for witnesses, or sometimes we call them the bystanders, to be upstanders, you know, yeah, to either intervene. So there's the different strategies, like, you know, simple strategies that we kind of educate the public to say that, you know, you could actually break the process by, you know, asking a question like, you know, do you need help, you know, and that kind of stuff. Of course, in very severe cases, we will encourage the public or the bystanders or the witnesses to actually report, yeah, and then let the professionals, you know, sort out, you know, where this case or where this family should be served, like, in terms of or receiving the level of intervention, yeah.
Thanks, Tabitha. Yes, please come in. We have probably time for a couple more comments or questions from the audience.
Hi, my name is Leilin, and I'm a medical social worker from the Institute of Mental Health. I recall this morning when Dr. Ng Wai Chong said that GPs in the private sector work alone. But my sense is that actually they don't need to work alone, because if they see an elderly person with a bruise on their face, there are so many family service centers and even family violence specialist centers around. They can find out which is the nearest family center to their GP clinic and escalate the case to the GPs, or even to call the National Family Violence Hotline, you know. But of course, it would be good if they can get permission from the person. Can I link you up with a social worker? So my sense is that I think our GPs can be educated to escalate cases either through the hotline or through the family service centers that are near to their clinics. So I really feel that there is avenue, but whether we can get our GPs, private GPs, to be on board with us. Yeah, thank you.
Thank you. Changing the culture of the ways in which these professionals work might be part of that, I guess. Any final comments people would like to make? Can we hear? Speak loudly.
I wanted to bring a different perspective about, that's good, thanks. About Molly and George relationship. And the first one was, because the nature of the case study, there are usually some information that's missing, and that's good because it allows us to ask questions. But I also wanted to know what was the relationship between George and Molly when they were younger, and as they grew older. Was the relationship cordial, or was it full of fraught with a lot of conflicts? Because that makes a difference in how caregiving will be determined or given. The other question that ran through my mind was whether in the past George was a caregiver for Molly, and now the relationship has changed, or the role has changed, where in the past he was her caregiver, and now she finds herself in a caregiving role because it's about duty. And so she's not really stubborn that she doesn't want outside help. Maybe she feels that if she calls others to come in to help, she's not doing her duty that was, you know, the care that she was given when she needed from George. So I think that questions like this that we need to ask, rather than think that there are services out there and she's not willing to access. And finally, in this entire conference, I haven't heard anything about spirituality. What is the spiritual belief of these two people, and whether we can tap on that rather than looking at biomedical services as a form of solution? And what about the cultural values and belief, not not only within the community, but also within the family, because every family have their own values and beliefs. So these are things I think we need to ask and tap on to, if we are really serious about helping people like that. Thank you.
Thank you very much. Really important insights into, I guess, elements of the case that we need more information about. The history, the dynamics, the nature of that familial relationship. And as you say, a place for understanding spiritual connection, both in the family potentially, but also marshalling wider community, spiritual resources, as it were. We shouldn't forget about it. And thank you for bringing that to the table. Maybe we'll talk more about that tomorrow, possibly. Please.
Sorry, can I make a comment, please? Hi, everyone. My name is Siu Lee. I'm a social worker, and now I'm involved in area of patient advocacy and patient experience. I think one of the concerns that I have is how we struggle as healthcare professionals or even social care professionals to refer families out for care. I think we know that community services can make a difference to whether a family can cope. But in truth, we do have difficulties accessing community services. Either they're not available, they're not affordable, or they're not personalized enough, because many of the vulnerable adults do have very specific needs. And I think in the community care setting, I don't think it's deliberate, but I think they do have fears. They have a lot of concerns. Some of them don't want to take on the case or take on the referrals. And it could well be to do with manpower issue or an issue of confidence or competence. But I think there are issues in terms of accessibility. And I think this it's very necessary to take away the stigmatization. I can imagine a family who finally agrees to the service, and then the service provider receives a referral and says, no, I cannot take because I don't have that manpower to manage the behavioral difficulties. And that gives you a message that you are a problem, right? I think we're all professionals, wanting to make a difference, and I think this is something we need to look at. While it's not directly related to clinical ethics, but it is part of it because it looks at how we support. How best do we do it? Is it from our perspective, from their perspective? I know there's no answer, but I just wanted to raise this concern. It's a very real issue, I think.
Thank you. I think that's really important, that the idea of stigmatization around care, and particularly in an environment where we might think that this requirement to be a good family caregiver is so central to what the society might demand. Those who struggle, those who are perhaps unable to balance responsibilities may feel like failures. They may feel stigmatized. They may feel they lack that sort of resilience that comes with that. I think that's a really important point. We are going to have to close the discussion soon. I just see one final comment, if we can. So we get two more comments.
I just want to quickly respond to Sudi's point.
Yeah.
So I said I work in a senior daycare center, so I'll give you that perspective from where we are, which is that we do want to take clients, senior people who need the families need respite. But what really constrains us, as you said, is manpower. And the problem is this, AIC, and unfortunately Martin's gone back, but he should hear this, because the way it's calculated is that one of us has to look after 6 to 8 people in the senior daycare center. And I've done the numbers. If I take an elderly man to the toilet for 10 minutes, I've neglected the other 7 for 10 minutes. And so my colleague has to backfill me, and he's looking after another 6 or 8 people. So the pressures on the ground are enormous, because my center manager has to make the call. If she takes that gentleman who has a behavioral issue, it means that disproportionate amount of time needs to be spent with him, which means we neglect duty of care to the other 8 people that we are looking after. And the problem, I know it's an averaging issue, right? We think that on average we should be look after 6 to 8 people, but unless they've actually done the work, I'm not sure that it's feasible to look after 6 to 8 people who have a bunch of frailties. And so that should be nuanced depending on, how frail are they. But because you apply this general ratio in Singapore, which actually just cherry pick the clients on the basis that these are manageable and these are really difficult, we just have to reject them. So AIC has now done the thing where the center manager has actually no basis for rejecting unless there's an enormously strong case. So you have to write lots of papers on why this person cannot be managed. So there is no easy solution, but I think there needs to be a recognition that every individual is different. And so the centers which actually look after them should be given some latitude on what's in reasonable amount of care so that we don't neglect the duty of care to the other existing clients when we're forced to take someone in. Thank you.
Wonderful, thanks. Yeah, we haven't talked a lot about the communal living environment or the communal care environment. You're absolutely right. We're thinking about reasonableness. We've got to think about justice and the just distribution of care. And I think that is something we need to not lose sight of when we're talking about the intimate familial context. It's a very different set of issues. We have time for the final remark, which I think is at the back. Please.
Okay, thank you. Thanks for giving me the last comment. I thought that a lot of times in deciding our course of action, we are very outcome focused. We always think about substantive values like, beneficence, non-maleficence, justice, autonomy. All these are outcome related values. But I think what I hear a lot today is also very process oriented kind of ethical values in terms of trustworthiness, in terms of transparency, inclusiveness, engagement. So I think a lot of times, sometimes if we think too much about what would be the right course of action, sometimes if we focus on the process and doing the process correctly, I think sometimes the solution shows itself. Yep, that was my point. Thank you.
And that's a great way to finish, because it brings us full circle to the kind of core ethical considerations that we set up this conference to discuss. And I think you're right. There is a sense in which what's at stake here is about the dignity in the care we provide, the building and maintenance of trust and such like. So that, I think we definitely want to foreground and not lose sight of that. Whether that means outcomes are totally out of the picture, I'm not sure, but certainly perhaps the recalibration of outcomes needs careful thought. I'm going to soon hand over to Sumi for the final words, but I've got the task of summing up. And to be quite honest, I don't have much more to say, and I think the discussion has almost concluded itself in some ways, plus you've heard a lot from me this afternoon. I do feel that we're quite a long way from clinical ethics in the standard sense today, but the richness and the depth of the discussion and its sort of ethical sophistication of it has been really impressive, and the contributions people have made have really, I think, put the meat on the bones of some emerging ethical ideas that are quite new to this room, to us all, to Singapore in general. And that's great. There are clearly questions being posed that answers are not yet forthcoming for. And I get the feeling that when it comes to configuring vulnerabilities in relationships and care, we've got quite a lot more thinking to do. And it seems to me one of the main challenges there is how we develop a systemic set of responses that are appropriately tailored and configured to the uniqueness of families and the uniqueness of individuals who need care in their own personal spaces. That's not an easy circle to square. We need models that are responsive in heavily contextualized and personal ways, and I think we've got some more thinking to do there. I also think we've really emphasized the troubling way in which we could allocate focus or blame in how we think about care and stigmatize it accordingly. So it seems really important when we think about the ways in which vulnerabilities manifest in caregiving relationships, we take that relationship seriously, its narrative, its history, its future direction. We grapple with its complexity. We don't try to pigeonhole or box the caregiver, the care recipient, the abuser, the abused into making sense of simplistic solutions. So hard questions, social questions rather than clinical questions perhaps, but important questions. And we will continue those questions tomorrow in different topic areas. And that's more than enough from me. So